Hello, welcome to Health Policy in a Global Context. We're going to start our third module, Healthcare Cost and Quality. So today we will see how healthcare is produced, the production function of health. We will relate it to cost and measures to control cost. And we will also see a dimension in healthcare quality, how it works, how it's measured, and how this concept is important to have a broader perspective of healthcare. So let's start our session. In this module, as I said, we will cover healthcare cost and quality. We will describe and explain the issues of healthcare cost and quality. And we will start with understanding or kind of giving a description, right, of how health care is produced. This is an economic perspective, right? Which we understand health or health status as the production, as the result of producing or production of health using some inputs, some healthcare inputs. And these inputs, of course, are from infrastructure, equipment, to staff, nurses, physicians, and other resources in healthcare, medications, labs, etc. All these inputs are used to improve the health of individuals, of a population, and we can describe that as we describe the function, the production function of goods in economics. And as you can see, the shape of this production function is reflects a characteristic that is common in goods, but it's also common in healthcare, and is the decreasing marginal returns, right? Where you, given a number of inputs, can produce health, right? And if, of course, if you start providing more inputs, meaning, for example, more healthcare, right, to a person with or a population with some diseases, then you definitely will improve the health status of that population. And that way you are able to produce health by using more healthcare inputs. And the shape of this function, as I said, with decreasing marginal returns, is very, increased very rapidly at the beginning when we start providing initial healthcare inputs, but then it becomes flat when you start providing more and more healthcare inputs. And that really reflects the fact that at the beginning, when, for example, you have a poor country, right, and you start providing, let's put sanitation, the impact, the gains of sanitation in terms of health are huge, given that there was nothing before. Then suddenly, when you move and you transition from a low, poor country to a middle low or a middle high or a high country, those possibilities of producing more health really require more inputs, right? So with the same number of inputs, you will achieve lower and lower health. And that meaning, right, the returns, right, the returns of these healthcare inputs, the marginal, the incremental returns of healthcare inputs are decreasing. You can see that more clearly here when we see the health status and some units of healthcare inputs, right? So if you can imagine, healthcare inputs is a combination, is a set, a basket of different resources that help patients, right? But it's not only medical care, it could be also public health. And we move from providing one unit of this basket of healthcare inputs to 2 units or 3 or 4 or 5. And at the beginning, when, again, if you are in a poor country, when you start from nothing to something, the impact on the health status of the population is very big, right? It's like from moving from one healthcare input to 2 healthcare inputs, you have an increment in health of about A, right? That magnitude, that change. And this is marginal, again, because it goes from small increments from 1 to 2. That's one increment in health status. It's producing a return of the magnitude of A. But if we start moving to a more wealthy population, for example, right, and where you already have covered the basic needs, and now you are covering, some additional needs that are not so primary, so important, more secondary or tertiary needs, then those impacts are getting smaller. And again, the same magnitude of increment, the same marginal impact, all right, from 4 to 5, that's again 1 unit, will produce a return in health status that is smaller, is of the size B, which is smaller than A. So as you increase the number of healthcare inputs, the effects of total health status decreases. And again, that's the diminishing or the decreasing marginal return of this function. And we can think of examples of why that happened, right? Again, if you start in a very poor population, providing basic sanitation, for example, public health, or, putting a doctor in a rural area where there was nobody there, right? No, only the population, no healthcare, no hospitals, no doctors. And then suddenly you provide this area with their first doctor. That will have a huge impact in the population, right? A huge increase in health. But then having a second doctor in that same town is going to have an improvement, but not as the first doctor, right? And having the third or the fourth doctor will have a smaller and a smaller impact. Eventually, in a population of 100 people, if you start putting 2 doctors or 3 doctors or 5 doctors, there is a point where really more healthcare inputs are not going to do anything on additional health status. And that is the flat area of this production function, right? Of the way you produce health with inputs. Eventually, this could be negative, and we can think about some examples where this becomes negative, like unnecessary treatments. Let's say, just consider the case of vitamins, right? You can, there is a need of vitamins in poor areas, and providing vitamins to kids, right? That really have a big impact at the beginning. But now, for example, in the US, we have a lot of people consuming vitamins, and the evidence shows that in many cases, people have already, the needs of vitamins, and they don't need, a lot of new vitamins. I mean, they probably need one specific, but not those, multi vitamins that we get over the counter. And that, in that regard, they can really produce nothing, right? If you already have your D vitamin level in the optimal, taking more vitamins are not going to increase anything. It's not going to do anything else to you. So that we are in the flat. But we know that some vitamins are really detrimental. They can affect if you have excessive number of those, of amounts of those vitamins, and that can actually affect your health, right? So you can imagine situations like taking some vitamins that are not good when you take it in excess, can really decrease your health status. Same thing, you can put the example also of ultrasounds in during pregnancy. You can have, more healthy inputs, and ultrasound is very good to detect, risks, pregnancies that are at risk. So the first ultrasounds are really, adding value, but then more than 4, more than 5, they really don't do anything for a normal, healthy pregnancy. But eventually, having too many could be also detrimental. Not because of the damage that it can produce, but the evidence that shows that when you have too many ultrasounds, it's more likely, for example, that you will have a cesarean section. And a cesarean section is low quality, it implies more risk. And if it's not needed, really, it will affect your health. So overutilization sometimes could really produce reduce health status, and therefore we can move not only to the flat area of the production function, but even to a negative area, which is not common, right? To be honest, but in most cases you will have this big increment and the flat section. But again, think that negative reductions in the production of health with more healthcare inputs are feasible. So of course, this is given the current technology, right? The current environment of health, the same health system. But we can improve health with the same inputs. So it is possible that we can be producing health as a point in here with only 4 units of healthcare inputs, and suddenly, just with the same inputs, we can produce more health if we have innovations, for example. So let's now do a little change to the production function, and instead of a basket of different type of inputs, we put a dollar value to all those inputs, and then we add up. We add all those and we get the expenditure, the medical care expenditure. So it's the same idea. Instead of inputs like quantities of number of doctors, number of nurses, now we have a total medical care expenditure. But it reflects the same thing, the same basket of inputs. And again, health. So the shape is the same. Here we have this negative piece of the production function, right? But the important thing is the growing part and the flat part, eventually a negative part. And there are factors other than medical care spending that will shift this production function. For example, public health, right? We can have public health, like sanitation, for example, that can shift this, this production function up. We can have innovations in technology. For example, we can have AI, a new innovation that improve the accuracy of, radiologists, for example, right? When they are supported by AI technologies, the accuracy of the readings of these tests are much better. So with the same cost, right, we have now an innovation that can improve the accuracy and therefore produce a better health status, right? Because you will get the treatment for people who are getting the right test now, more accurate tests. So this could be a possibility, right? Or a new drug that came to the market that can now, improve the health of individuals spending kind of the same, right? So I think in terms of these obesity drugs that not only reduce obesity, but also improve diabetes, right? And other diseases. So therefore, with innovations, we can shift the production function of health up. And eventually, we can also have situations where we can reduce, right, or shift down the production function of health. So think in terms of COVID, for example, right? A change in the environment, right, through a large epidemic that really deteriorates the health of everybody. And therefore, with the same cost, for example, in cardiovascular, right, after COVID, people didn't have access to healthcare. They were afraid of going to, or doctors were not doing surgeries. So all the production was affected due to COVID. And therefore, we produce less with the same number of expenditure, right? So that therefore, implies a shrink, a reduction, a shift in the a shift down, right, in the production of health. Now, these are, of course, representations of the population, a population, right, and the the inputs that you need to produce health. But we can think on specific programs as well. And behind that, you will see the same idea of the diminishing marginal returns. So let's, for example, consider this case of two programs, right? We compare two programs. One is a community health center program, building community health centers in an area where there are no community health centers, right? So imagine a poor area and there are no community health centers, and now we start adding and building community health centers. If we build the first one, it costs $100,000, that additional cost, right? And we can have a savings of 100 lives thanks to this community health center. Now you can build a second one in the same area. Let's assume it costs the same. And of course, because it's the same population, right? The benefits are still good, but not as big as the first one. So the second community health center can save 90 lives. If you are a third one, that will still be good, but it will produce less, 75 lives saved. And the fourth, 55, finally, in this example, building the community health center number 5, that costs $100,000. That community health center will save 30 lives. Now, compare that to the production, right? This is kind of how many lives are saved. This is a production of health associated to community health centers. So we can now think about the production of health of anti-drunk driving campaigns. Anti-drunk driving campaigns, you can have one campaign cost $100,000 for this example. Let's assume it costs the same, but it saves only 40 lives compared to 100 lives. Now, if you do a second, it saves only 35. That second campaign will save 35. So total, 75, right? So if you do the third, then it's 28 lives and so on. So clearly, you can see that it's much better, right? It's more efficient, right, to produce health with the community health centers than with the anti-drunk driving campaign. So you can see these two functions, and one that is dominating the other one. Community health centers is superior, is dominating the anti-drunk driving campaigns. And therefore, most likely you will invest in community health centers. We will see that later with more detail, but of course, the way of looking at this is, okay, if I want to produce health, what am I going to do? Which one of these programs I'm going to pick? The way to do this is to say, well, let's say I have $500,000, right? And you can say that with $500,000, you are saving 350 lives. That's good. And that's much better than spending the same $500,000 in anti-drunk driving campaigns because it only produced 126. So what are you going to do? Are you going to build 5 community health centers? Yeah, be careful. The way we analyze this is on the marginal things, right? By one. So let's start. You have $500,000. We want to spend the first $100,000. What are you going to do? Are you going to build the first community health center or the anti-drunk driving campaign? Yeah, it is better to do the first community health center because you will save more lives here, 100 compared to 40. Now let's think that you have $100,000 more to spend. So total 200. So in that case, what you are going to do is to say, well, should I build the second community health center and gain 90 lives? Or should I do my first anti-drunk driving campaign, spend the $100,000 and get only 40 lives? Still, it's better to do the second community health center. So you will do the second. Now you have another $100,000. What are you going to do? Build the third community health center for 75 lives or do the campaign for 40 lives? You will definitely prefer 75 than 40, so you will do the third community health center. Then you have $100,000 more. What are you going to do? The community health center number 4 that produce 55 lives, or the first anti-drug campaign. You will still do the community health center because it saves more lives, saves 55 compared to 40. And then you have the last $100,000 of your total of 500. And then you say, well, what am I going to do to build the 5th community health center and get 30 lives, or to do the first anti-drug driving campaign and get 40 lives? So now 30 lives is less, community health centers produce only 30, which is less than the first anti-drug driving campaign that produced 40. So I will spend the last $100,000 in the anti-drug driving campaign. So as a result, I will have 4 community health centers, 1 anti-drug campaign, and the total lives that I will save are 360, more than just doing 5 community health centers. Okay, 360. So that's the way we analyze in the margins. And again, why is this happening? Because you are basically in the flat area of the production function of health in the community health centers when you are here in the 4th or 5th community health center, but you are in the growing area of the production function of the anti-drug driving campaign when you produce the first one. So at that point, it's good to have, to invest those last $100,000 in the anti-drug driving campaign. Okay, so why, this idea of the production function tell us is that there are ineffective ways of producing health, right? And one example is, of course, in unnecessary diagnostic procedures, right? So we do a lot of tests that are not necessary, that are wasting money, basically. And there is, of course, an evidence-based practice, which is telling us, in other words, that we are getting the maximum benefit. So think about that production function, right? If we do too many unnecessary diagnostic procedures, we are in the flat area of the production function. But if we do what the evidence-based practice recommend, we are in the growing piece, right? Probably before it becomes flat, there is an optimum number, which is based on evidence, and that evidence is built on what are the benefits and the harm, right, for this population. And therefore, we need only 4 prenatal tests, prenatal visits, for example, for pregnancies. That's enough when you have a healthy pregnancy. Beyond that, it's unnecessary, it's waste, it's ineffective. And we need 4 because the evidence shows that 4 are enough, for comprehensive visits. So, so again, the evidence-based practice will tell us what is the optimum in that production function. Above that is unnecessary, it's a waste of money. It's like producing, it's like building the 5th community health center when it was more effective, much more efficient to do the first campaign in the example that we saw before. So that's one, idea of why unnecessary diagnosis, overdiagnosis is not good in terms of efficiency. And another idea is this huge expenditure in administrative costs, right? So the US spend between 15 to 25% of all the healthcare spending on administrative costs. That is insurance marketing, right? Billing, all the codes that we have to submit to the insurance market needs people billing, doing the billing. That's administrative costs. That's a waste of money. Claims processing, utilization reviews, people who have to check if that was allowed by the insurance or not. So all these administrative costs really shift the production function of health downward, right? Because now with the same money, you produce less health. Why? Because you are using that money, or a big chunk of that money, between 15 to 5% of that money, for administrative things, not in health, not in curing, treating people. So that means money wasted and production of health being lower. So that's a good example, right, of shifting the production of health downward. Now, let's think about a way to shift the production of health up, and that's good preventive care, right? Investment in prevention. Yeah, you know, an ounce of prevention is worth a pound of cure. That goes to say. But the idea is that yes, prevention can avoid more expensive care, right? So you have a good prevention system, you can avoid that a person with diabetes get their, his leg amputated, or, become blind, or, all other consequences of that disease. So prevention really helps. Now, it is important, we will see that later in other modules, it is important to recognize that yes, prevention can actually save money. You can spend $1 in prevention and save $2, right, in avoided treatment, surgeries, emergency visits. That is a saving, right? Because you spend $1 and at the end you gain $2. So that means one profit, right? One saving, $1 saving. It's worth it, of course. Yes, that's true, but in a very tiny fraction of prevention care. That's, again, a large set of cost effectiveness or economic evaluations show that, yeah, there are savings, but they are not the majority. It's a small fraction where you can really see savings. In most cases, there is a cost of prevention. It's meaning that if you spend $1 in prevention, you can have benefits of 80 cents, for example. So at the end, you spend $20, 20 cents, sorry, but you improve the health status of people. So it's still cheap. It's still cheap to really invest in prevention. It's still worth it. But keep that in mind. It's not free, right? It's not free. You need to invest and spend money to avoid something that is more expensive and improve the health status and shift that production function up. But it's also the case in a small fraction, where prevention is not good, where prevention could be worse than the cure. And that happens when you target high-risk population for something like, for example, HIV. You can do HIV tests, and that's good, but that's good if you target high-risk population. Because if you target low-risk population, where there is only one case among 1,000 people, right? In that population, they are very, they have all the characteristics of, they get very protected, etc. Then it is a waste of money do those tests or screen for HIV when there is very rarely few cases that you will detect. And that in that case, prevention could be more expensive than the cure. It's cheaper to treat that one person out of 100, 1,000, than give the prevention to the 100,000. So in those cases of low risk populations, prevention is not a good idea. So if you do prevention, you have to be smart and target the right population. Another example of prevention is where it's really worse than the cure is mammograms, right? So in mammograms, for example, you won't do mammograms at a person who is 20 years old. Yes, you may detect one cancer, maybe, but one out of thousands, right? And given the cost of mammogram, and most importantly, given the rate of false negatives, so just imagine the number of people that will get a diagnosis of cancer when they don't have, because it was a false positive, the test is not perfect. those people will have harm in terms, psychological harm, extra tests, etc. So at the end, you have to compensate. The false positives and false negatives really are important in justifying not to do prevention like crazy, right? Because when you do those tests, there are a lot of false positives or false negatives, and you will start treating people who don't need that treatment, and you may affect those people, the health of those. So if when there is a low risk, the false positives and false negatives are bigger. uh, yeah, that happen especially in younger population when you do those tests, or low risk population as well. So important to keep that in mind. Prevention is in general very good, and it's a good investment. But in some cases, so don't take it like always doing prevention. No, in some cases it could produce more damage than than good. So we have to be strategic and smart with prevention.